Thank you, colleagues, for your questions. There's quite a flurry. We'll try to get to them. I just respectfully ask the panelists to please be brisk in your answers. I know that we probably do PhDs on all of them. We'll start with Durhane Wong-Rieger. First of all, just to say to you, Durhane, there's still time to see you in Parliament, but that's for another day. My question is, when you're doing advocacy for government, for example, for special access, what works? I mean, do you have to protest? Do you have to have a celebrity endorser? What works?
The answer is that everything. We talk about the fact that, you have to have patience. And this is why people like Maureen and why, in fact, Scleroderma Canada has actually been recognized by court as one of our premier patient advocacy groups. You have to start with patient stories. People respond to other people respond to real cases. And certainly, as you heard in her presentation there, it's powerful when she talks about the impact. But that's not enough. Obviously, we know that. Even when they are celebrity patients and endorsers, it's not enough. You do have to have a patient, you have to have groups, and you have to have multi-stakeholder groups. So we really find that engaging the patient community and the healthcare community is powerful. Patients say, yes, this is important, but oftentimes, they turn to the physician, they turn to the researcher, and they say, is that true? Is that really what's happening? So they need that validation, but they need everybody then to talk together. You've got to be able to have that same voice. But we always say it doesn't matter. You can do a lot of protests, you can get a lot of public support if you're, really visible, if you're loud, you can get a lot of public attention around it, but you got to get to the table. And that's where you do need to have. And sometimes it will be consultants. I mean, Lorraine has always been one of those premier advocates. You have to be able to get to the door. You have to get to the ear of the policymaker. Sometimes at the table, sometimes it's privately. They've got to hear from people that say, pay attention, this is important to you. Or get to a decision-making table like HESA, etc. So you've got, but those have to be credible people. And if we say sometimes the best advocates outside the door are not the best ones inside the door. So again, you've got to have that function. You've got to have your facts, you've got to have your figures, you've got to have the absolutely evidence around what you're saying. And so it takes all of them working together. Nobody can do it on their own. This is what we've been doing in advocating for a rare disease strategy, for a rare drug strategy. We use all of those. And even then, 90% of the time we lose. So just be prepared for the fact that it doesn't work the first time around.
Thank you, Dr. Wong-Rieger. We'll now move to Dr. Gniadecki. We have an interesting question about what patients are after sometimes with regard to alternative therapies for scleroderma, if any. Do things like acupuncture and cupping and that kind of whole list have any place, or is it much better to just stick with straight biologic therapies? I should also just mention there's a little bit of interesting background noise, like we're on some kind of a space shuttle. So if anyone can just mute themselves while not speaking, that'd be great. Dr. Gniadecki, please.
My goodness, thank you for the question, but I'm just a dermatologist. And frankly, in dermatology, you see all those patients trying different alternative therapies. I cannot comment on this. I'm so sorry. I wish I could. I think acupuncture works in many instances, especially in patients with pain, but I have no data and no experience. So I have to disappoint.
Thank you, Dr. Gniadecki. Ms. Boyle, one of the interesting things you mentioned during your presentation was the demonstration of clinical value versus economic value. And I guess the question is, are those hard numbers? Is a moral decision? Do people just kind of decide on a whim? Does a patient have to be related to the member of parliament? Like, how does that actually work?
So when we talk about clinical value at the outset of new products coming in that have been tested in small trial populations, that's the challenge, is that it is a very controlled trial patient population. And so what's helpful for the payer decision makers to hear is about what is the current treatment paradigm and what is your current experience with the disease, and how could this new treatment potentially fill that gap and address the question. On the economic side, oftentimes the data that's required is economic data that was collected through the trial program. So it might be healthcare resource use as a result of the existing therapies versus what is the healthcare resource use like with the new treatment in place, and how does that improve the economic value proposition with the new therapy coming into the market. So those are the two areas that I would say are most important and most essential to talk about.
That's great. Thank you, Ms. Boyle. Ms. Sauvé, first of all, thank you not only for your advocacy, but also for sharing highlights of many, many patient journeys. I guess what I would say to you, there's a number of questions for you, but the one that struck me was, we have a number of practitioners who are listening. What advice would you offer to them when they might be inclined to, as you mentioned, dismiss symptoms of scleroderma in women?
Well, I think that knowing your patient would be first. I know that in any community of people, there are those who whine a lot. There are those who always have a headache, always have a cold, always do. And it's easy, therefore, to dismiss these issues. But for many women, they aren't, they're reluctant to talk about their own health issues. They're busy raising their families and working and doing. By the time I go to the doctor, I probably should have been there 2 weeks ago. And I'll tell you, my rheumatologist would agree with that statement. But so really, it's just know your patient. And if they come back more than once, if I come to you and I say, so my own personal journey, I went and I said, something's not right. I'm a bit of an A-type personality. I work hard. I've always got something on the go. And my fatigue level was becoming debilitating. I had these other symptoms, so the doctor sent me for some tests, some blood tests, and an X-ray of my hands. So I got a phone call from the doctor's office. Good news, it's not rheumatoid, and that's it. So I called back a little while later, and I said, okay, so your test results in, am I setting up an appointment? And they said, oh, no, your test results were fine. So you're okay, don't worry about it. And I go, okay, so negative tests mean that I'm fine? It's dismissive. So I said, no, in fact, there's definitely something wrong. And for me personally, I had to throw a bit of a fit and say, I respect that you don't know what it is, but I don't respect that I have to chase you for the next test. So if I come to you and I ask and I say I've got a problem and the tests come back negative, it doesn't mean I'm fine. So I like I said, starting, I don't think that most of the women I know are complainers at the doctors. So if I start complaining about fatigue, you should be listening, because it's an indicator that something's not right.
Thank you, Ms. Maureen. And a question for you as well. From your leadership roles in the various scleroderma associations, and maybe your own just kind of anecdotal personal experience, how effective is a Dr. Google search? Does it lead you kind of wayward? Does it kind of give you the right printouts to go and hand to your doctor and say, hey, doc, do this?
Well, in the end, that's where I was. So that is a personal story. After months of chasing, trying to get things done and being told that I was fine. I mean, I even went to a private medical clinic where I paid thousands of dollars to be told I had osteoarthritis in my hands. It was really, I was starting to think I was a hypochondriac. So I started Googling and just Googling my symptoms. And no matter how many times I Googled them, this stupid rare disease kept coming up. And then I really thought I'd lost my mind. But in the end, I went back to the doctor and I asked him to rerun an ANA and take a look at that, because I thought that would indicate what the problem was. So does it lead us in the right? It leads to scary information mostly first. But I know a number of patients who had been diagnosed with lupus. In the end, my GP said I had lupus. I told him he was wrong. It wasn't, it was scleroderma. Even the ANA pattern that he had on his screen indicated that it wasn't lupus. So I had really deep dived the information at that point. Wow. So yeah, I can lead you to the right information if you're tenacious, but it can also lead to some difficulty. I mean, the first time you look at that diagnosis and go, really? And you're by yourself in front of a computer, it's really not the best alternative. So, but yeah, it certainly does lead patients where it needs to go most of the time.
Well, thank you, Ms. Sauvé. It sounds like you did your own home PhD in the field. So thanks, Ms. Boyle, Drs. Wong-Rieger and Gniadecki, and we'll now move to, thank you for your contributions and your questions and answers. I should also mention, we do have a second panel coming up later in the afternoon. So please do continue to send us this flurry of questions. We'll hopefully try to get to them either today or other fora. And we'll now move to our next presentation. Thank you all.